Good morning, everyone. What a pleasure it is to kick off what I literally call the hottest session in cardiology. We're talking about inflammation today. Before I set the stage for what we're going to discuss, I'd love to invite my co-panelists on stage. We'll start with Dr. Chandrasekhar, Chief of Cardiology at the Minneapolis VA Hospital and Associate Editor of the ACC JACC Imaging Journal, and he will also be delivering our pace setter this morning. Next, Dr. Ami Banerjee, Professor in Clinical Data Science, University College London. Dr. Tom Ribeiro, Professor of Internal Medicine and Vice Director of the Center for Artificial Intelligence for Health in the University Hospital of the Federal University of Minas Gerais. Dr. Anna Munera, who is the President-elect of the Inter-American Society of Cardiology, Internal Medicine. And finally, last but not least, one of my favorites, Dr. Sid Smith, Professor of Medicine at the UNC School of Medicine and past President of the World Heart Federation and the American Heart Association. So for the last several decades, we have talked about cholesterol, we've talked about hypertension, we've talked about endothelial function. And this is something we call cholesterol risk for coronary artery disease. And yet, there's something called inflammatory risk for coronary artery disease that we have really essentially neglected to talk about. Now, I remember back in medical school, when I was a first-year medical student, we got a lecture from Paul Ridger on what inflammatory risk is for atherosclerosis, what an angry plaque looks like as opposed to a happy plaque. And yet, decades later, I don't routinely assess inflammation in my patients. I don't even know how to assess inflammation in my patients. Is it just a biomarker? Is it imaging? Is it a combination? Is it comorbidities like rheumatoid arthritis or psoriasis or others? So this morning we're going to dive deep into inflammation, into the inflammatory plaque, into inflammation and atherosclerosis, and we're going to talk about what we call added inflammation, which means inflammation on top of inflammation when we layer on multiple diseases like diabetes and chronic kidney disease and obesity, where the final common pathway of all these conditions is inflammation. We'll talk a little bit about the practicalities of bringing inflammation to our patients as individual providers, but we'll also talk about what we can do from a systems level to screen the population for inflammation and whether or not that's worthwhile. So without further ado, I would like to invite Dr. Chandrasekhar to help us understand inflammation a little bit better and to set the stage for what we need to think about when we think about our patients and inflammation.
Good morning. Very happy to be here, and thank you, Dr. Kohli, for the kind introduction. The topic we have today is probably central to everything we do and everything we talked yesterday and today. And essentially, it answers the question, why do we have bad things happen with coronary artery disease? So let's get going. I was told to kind of, the audience is of mixed interest. Some are action, some are policy, some are scientists. And so we'll kind of keep it in a general high-level discussion, and then during the panel discussion we can go further deep into various topics. I have no disclosures. So the question is, why does coronary artery disease, something that we are so scared of, why is it bad, right? Is it the stenosis it causes? Is it the events it causes? Is it ischemia that it causes? And this has been a big controversy for many, many, many years. And we are close to getting some answers for these things, but let's see what the data shows. So traditionally, we thought that people wouldn't have events if they don't have coronary artery disease. That remains true even today. And one way to assess risk in the current environment is to see if somebody has coronary calcium, which is like the signature of atherosclerotic disease. And here you can see a patient who has no coronary artery calcium. And we would generally say this person is not at a high risk for events. A few years later, the patient then develops this, which is like a CT scan showing that he has now developed a plaque where there is a little bit of an obstruction in the coronary artery disease, which puts them into a certainly higher risk than what it was a couple of years ago. And we always have to ask the question, what made the change? Is it that they were eating too many hamburgers and they deposited cholesterol, which was the traditional view? Or is something else happening that is making them go from zero coronary artery disease to manifest coronary artery disease? Fast forward a little while later, the next event is myocardial infarction and death. And so then the question is, you wouldn't have expected the patient with that kind of an anatomy to have myocardial infarction and death. So what is it that happened? And the traditional thought has been they would have had a progression of their coronary artery disease. So from there, they went into a higher degree of coronary artery disease, like in this picture. You can see there's a narrowing there, and that caused the events. But there is more to the story. And because naturally, when you saw stenosis, the answer was, okay, let's put a stent, we would fix the blockage, and then that would save him from having events. But what's coming out more and more is that we are looking in the wrong place, and we all know the story of a drunk coming out of a bar, and under the street light, he's searching for something. A policeman comes and asks him, what are you searching for? He says, I lost my watch. The policeman says, did you lose your watch under this street light? He says, no, I don't know where I lost it. And he says, why are you searching under the street light? And he says, because that's where the light is, that's where I can search, right? So the trouble is, we thought the stenosis was the problem, and that's why we were searching on things that we knew, but the risk is probably somewhere else. And here is what really happened in this patient. So instead of just going down the stenosis pathway like we would have expected, he had what was called a ruptured plaque and an aggressive kind of disease. And the question is, what caused this transition from just a little bit of coronary artery disease to sudden death? And the answer now is starting to come towards a different mechanism entirely, and that is this particular cell, the macrophage or inflammatory cells, that go and create an environment where coronary artery disease progresses rapidly. And here is an example of what might have happened. At a time when the lesion was just a little bit of narrowing, you had a thick fibrous cap, you had a little bit of necrotic core, and then when he had an event, you had just a few cells preventing him from catastrophe and a large necrotic core. And it now is appearing to be a fact that what dissolves this thick layer and makes this bigger and bigger is a combination of everything that we do health-wise or unhealthy habits, as well as a lot of inflammation that is chewing up all this and eventually chews through this and causes a myocardial infarction. So with that background, let us look at the thought progression. So like I said, previously we thought it is that you get this big deposition of extra layers of cholesterol, and then it narrows the lumen. This is the lumen, this is the wall, and lipid is causing this to kind of grow like a big mountain. But it turns out that these are the bad actors. They are the people who are going to dissolve this and break this open and cause a myocardial infarction. And why did it take so long? Because it didn't have a champion like we had for cholesterol, and this is Ansel Keys, who is to be a part of the University of Minnesota program. And he came up with this big discovery that cholesterol was the big culprit at a time when people didn't know why people were having heart attacks. And that kind of a leader wasn't there for us in the inflammation field, and the inflammation was difficult to see, unlike cholesterol, right? It was not as easy to measure. We didn't have evidence of intervening on it, and then we didn't have data on outcomes, which cholesterol had for many years. But that has changed in the last 10 years or so. And so let's look at what we know. What's the evidence for inflammation? Okay, the evidence for inflammation is been over 30 years of research. Especially, there were many people who were looking at this, but mainly Paul Ridker's group at the Brigham. And here is one of the first papers, which shows that in healthy people, this is a healthy physician study. In healthy people, as you have more and more CRP, which is like a marker for inflammation, people with more CRP have more events, whether they are treated or untreated. And in this study, they're looking at aspirin, and you can see people with inflammation reflected by CRP, which is like a systemic biomarker, they have high events. It went further into an interventional trial, the famous Jupiter study, where they took 16,000 odd patients who had cholesterol levels which were thought to be reasonable by those standards, LDL of 130 or less, and they were treated with rosuvastatin or a placebo. And the surprise of everyone, people who were otherwise thought to be within a healthy cholesterol range seemed to have a benefit if you gave them statins. And all these patients to start with had high CRP, which is a marker of systemic inflammation. So in a group with systemic inflammation, reasonably good levels of cholesterol, you can still show a benefit of statins, which brought to the fore the idea that statins also may be having effects beyond cholesterol, and the effect might be inflammation. And then there was subsequent data that this also attenuated the CRP levels, suggesting that it was acting through a mechanism that would have involved inflammation. There's further data that how does LDL interact with CRP, and you can see that they kind of are additive, and even in people with high LDL or not high LDL, CRP still remains an active player. So this is kind of the data that built up the foundation of where we are today. The other important thing that is coming up is residual risk. Now we are treating people with statins and all the good stuff, and the patient walks out healthy from our offices and then still ends up having events, not to the extent that they had before statins and before all the good stuff, but they still continue to have events. And this residual risk becomes very important, and that is the place where inflammation is probably having the greatest effect. And here is a study that shows that in graphical details, that in 3 major trials where patients were treated aggressively for secondary prevention therapies, it still turns out that a high CRP has a significantly high risk in portending future events, and this is a good way of quantitating residual risk. So the concept of residual risk despite aggressive therapy is coming up. So what else is adding up into this area? What causes this inflammation? We know now inflammation is important. There's a host of things that cause inflammation. Even the traditional risk factors that we talk about are probably acting through inflammation. There are a host of other triggers that can do, and let's talk about a couple of things that this can do. So how do triggers really act? So these are systemic triggers. They are systemic inflammation. It's causing systemic problems. And you will be surprised to know that there's been a fair amount of data that when a patient comes with myocardial infarction and has a ruptured plaque, angioscopy often reveals a couple of other minor rupture plaques into their coronary circulation, and some of them also have active plaques in their abdominal aorta and carotid, suggesting that this is like a systemic issue that came to the fore with us through either myocardial infarction, because that was the most dramatic presentation, but these plaque ruptures, plaque healing is going on all the time, and probably underlying inflammation is the pan-vascular insult in this situation. And of course, one of the biggest culprits of inflammation, as you will hear later on in this session, is of course sugar, which did not get the same kind of attention like LDL, but I think that is probably a worse risk factor going forward. And as you can see from the PURE study, there's already evidence that sugar is really, really not our friend. How about things to pacify inflammation in day-to-day lives? Of course, Mediterranean diet, good food, healthy food, and those are the basic stuff. But some of the other things that we should be thinking about inflammation is also that it's not localized to the heart. And here is an example where mental stress, through activation of bone marrow, macrophages and active elements, can result into cardiac effects. And here are 2 brain scans before and after treatment in a patient with psoriasis, and you can see that there is active changes in the brain happening at the same time when systemic inflammation is causing bad things. So we should start thinking about inflammation as this uber dangerous thing that's underlying lots of bad things that are happening. I was also asked to touch briefly on disproportionate inflammation. There are some conditions like HIV, rheumatoid arthritis, lupus, psoriasis, which can cause even more inflammation than the chronic low-grade inflammation that we talk about generally. And for example, here is a study in psoriatic patients at baseline and a year later, showing that if you treat psoriasis aggressively, you can pacify some of the plaque changes in their coronary artery disease, suggesting inflammation has triggered the change in composition of coronary plaque. How do you detect this? There are multiple ways, but broadly two things. You can have biomarkers or you can have imaging markers. Imaging markers could image an entire natural history of atherosclerosis, but specific to risk of inflammation, nuclear markers seem to be very, very promising. There are some new markers that are coming up, which are a little more specific than FDG, which is our non-specific workhorse for inflammation imaging. There are indirect ways of measuring it, probably. When there is inflammation in the coronary artery, all this cytokine release can affect the fat composition next to the artery. And with cardiac CT now, there is a strong push to measure what's happening in the perivascular fat by something called the fat attenuation index, which kind of looks at what's the Hounsfield density of the fat surrounding the coronary artery. And that, it seems, is a good predictor of future events, as shown in this big study from the Lancet last year, which shows that if you have high quartiles of fat attenuation, they have high risk. What's the management part of this? We know all this information, we can measure it, how do we target it? This is a summary of what we know. These are the things that have worked in the top left corner. There have been trials of statin, colchicine, IL-1 inhibitors, and now we have IL-6 inhibitors coming up. And of the three major trial class categories that we did, methotrexate did not show a benefit, but it's not surprising because it did not even suppress inflammatory markers very well. So the current front runners are immunomodulation, IL-1, IL-6, or colchicine, and as colchicine has been showing consistent data both in chronic disease as well as after MI. I just have a couple of slides. I'll just tell you the biggest excitement now is IL-6, right? There's a trial coming up and it shows you can reduce CRP levels. The big trial is awaited. So two concepts to take home. There is lipid-related risk is going down, so inflammation-related risk now becomes more and more important, so it's important for us to invest into that. That is one thing. And the second thing is, how will AI change this? This is a summary of all the AI technologies that are available to evaluate the entire coronary artery system in one go. And very soon, we will be adding plaque morphology as well as inflammatory markers to that, and that's going to really change how we look at these things. Thank you.
Thank you so much. What a wonderful whirlwind for inflammation. And, I want to start by saying that inflammation is one of those things that evolved to protect us, right? When we cut ourselves, how do we heal a cut? We bring in inflammatory cells to heal the cut and help us to recover. But it's this idea of prolonged inflammation. As Dr. Chandrasekhar said, inflammation that's turned on and stays on, or it's out of proportion, or it's the final common pathway for many of the lifestyle choices. I was thinking of all the arrows that he had pointing in there, and what I've been doing for the last few days with eating too much, not exercising enough, not sleeping enough, and having too much sugar, and what that may be doing to my inflammation. So I want to start by setting the stage of the context of why we got here with inflammation, where we're going to go, and then talking about systems-based solutions. So my first question for you, Dr. Smith, is can you talk a little bit about why we've had the spotlight in the wrong place. As he showed that comic, which I found really interesting, we're looking under the lamppost because that's where the spotlight is, but how do we move it somewhere else and start to look where we need to look, which is finding inflammation, and why have we neglected inflammation for so long?
Well, thank you, and I'd also like to congratulate Dr. Chandrasekhar for just a fantastic, beautiful overview of this topic. For anyone interested, go back and listen carefully to that lecture. The question is, how do we take a good idea and do something about it? And we can learn a lesson from cholesterol, which now it's been about 100 years since the initial findings were published on the relationship of cholesterol to atherosclerosis. It was published by Russian investigators and was discounted because they could not recreate the findings in another country. Well, how could this have happened? It turned out that the Russian investigators were using rabbits who develop atherosclerosis from high cholesterol, and those who tried to recreate this work used dogs. And as you all know, dogs don't develop coronary disease. You can feed them a lot of cholesterol and it just doesn't happen, except in rare circumstances. So finally, that was discounted, and it was understood that the work by the Russians was in fact correct. The Russian investigator was no longer alive and could not receive the Nobel Peace Prize or the Nobel Medicine Prize for his work, but work was underway. Still, the question raged as to what was the importance of cholesterol. In fact, of epidemiologic studies showing that it was important. I was still, this is 30 years ago, was president of the American Heart Association. There were arguments among leading physicians and academic cardiologists about was cholesterol important, and the 4S trial came out. And for the first time, we had hard evidence that the use of statins in this case could reduce, in secondary prevention, total mortality, cardiovascular events. And I tore up my talk for the AHA scientific sessions on the importance of interventional cardiology to stress the importance of comprehensive medical therapy to address risk factors such as cholesterol, hypertension. At that time, in that talk, there is a slide shown based on work by Peter Libby related to inflammation and its importance in the ulceration of plaques. Since that time, the publication of work by the Jupiter trial basically showed that patients with high HSCRP or CRP, evidence of inflammation, and treated for primary prevention with rosuvastatin by Paul Ridker had a benefit. So gradually we've been able to see that inflammation is important beyond its effect on ulcerating plaques. The question is, how do we take these data and make something happen? And that's where we need more evidence on outcomes. And as we heard summarized in this talk, the importance of IL-6, IL-1, inhibitors in those, it's colchicine. We're seeing increasing studies showing that there are a body of evidence that in patients well treated with statins who have a decrease in LDL cholesterol, there is residual risk. And that residual risk is related to the presence of inflammation and those factors that contribute to it. And so even now in the 2018 high cholesterol guidelines, which we published ACC, AHA, we made the point that the presence of inflammatory disease, rheumatoid arthritis, we talked about psoriasis, and you saw a beautiful example of that in the introductory talk. These are all risk factors, HIV, that need to be considered in addition to the level of cholesterol. Now we are left with what's the best way to treat inflammation and understanding that broadly it's going to be based on doing more than those factors that are associated with ulceration of the plaque. And that's why I think today's meeting here and these discussions are very important. The sooner we can get to economically feasible ways of addressing inflammation as an important contributor beyond the risk factors of high cholesterol, high blood pressure, and so forth, the sooner we'll get to a more comprehensive approach to decreasing risk of cardiovascular disease.
Wonderful, thank you. I mean, inflammation is trending on social media, right? I have young patients, I have older patients, everybody's talking about inflammation, anti-inflammatory diets, so it's not just us as providers, but patients are talking about it. But one thing I struggle with as a physician, a clinician who treats patients with inflammation, is that it's always the final common pathway. Whether it's obesity, diabetes, hypertension, chronic kidney disease, many of those manifest as inflammation. So Dr. Chandrasekhar, how do I decide if I treat the inflammation with an IL-6 inhibitor, or if I go upstream and treat the obesity with a GLP-1 receptor agonist, or treat the diabetes, and that'll just fix the inflammation? How do we know if it's primary or secondary?
Yeah, so for that we probably have to wait for a little while to get more data. But I would argue it's not one or the other, we do both, right? So right now we can take care of all the risk factors, which probably are the continuing trigger for smoldering inflammation going on for years, right? So if we can fix that, we can take care of a big chunk of this happening, like the subliminal inflammation that's going on. And then when you identify the big picture risk factors and people with the higher risk, those are the people you'll probably hit with the more potent cocktail for intervening. And that's what has happened already in my practice also. We've started doing that for MI patients, and now we also use colchicine for people who are non-MI but who have a significant coronary artery disease.
So do you assess the inflammation with biomarkers and imaging in your clinical practice, or do you just assume there's inflammation because they've ruptured their plaque?
Right. So for patients who already have known risk factors, we address the risk factors assuming that they have inflammation. Right now, for a routine inflammatory marker survey for patients, CRP is just like a one-time measurement, right? We don't have to keep measuring it repeatedly, although with therapy it does come down. We restrict fat attenuation index or some of those things to really research settings at this time. It hasn't percolated, at least into my clinical practice. And the easiest thing is when there's any doubt, we assume that if somebody has coronary artery calcium or any significant amount of risk factors, they have inflammation, and you start addressing the low-hanging fruit before you go to the advanced imaging markers.
Great. Dr. Munera, I want to come to you. I want you to talk a little bit about how we can tell and engage providers to start thinking about inflammation every day. Do we look at primary prevention population? As Dr. Chandrasekhar said, do we look more at the secondary prevention patients? How do we engage providers to put inflammation front of mind?
Thank you very much. Best regard to everyone. I want to share some statistics of the American continent. America has approximately 1 billion inhabitants. Life expectancy at birth is 77 years. America is a diverse continent with diverse race, cultures, and languages, with middle and low income countries with migration. The prevalence of hypertension in adults aged 79 was 30%. The countries with the highest hypertension, over 40%, were Paraguay, Republican Dominican, Argentina, and Brazil. The countries with the highest prevalence of overweight and obesity are the United States with 68% and Mexico with 66%. The prevalence of diabetes in Mexico is expected to be around 18%, representing more than 40 million people. Sedentary lifestyles reach 40% in some countries. Pollution exceeds the WHO air quality guidelines in the region of the Americas. This translates in increased risk factor and inflammation. Ischemic heart disease and stroke are the leading cause of death in the last 20 years. Alzheimer's disease and other dementias are now the third leading cause of death in America. And we all know the relationship between dementia, cardiovascular risk factor, and inflammation. The Inter-American Society of Cardiology, SIAC, includes 27 members, countries or society with 21 councils. At SIAC, what are we doing to help? We engage healthcare providers and communities and recognize the importance to managing inflammation, a risk factor for CAD, through 4 fundamental pillars. First, prevention and community education. Second, medical education. Third, advocacy. Fourth, networking. In prevention and community education, we have Council of SIAC Prevention, SIAC Women, and SIAC Community. Prevention, education, and community actions, campaigns, what we do. Cardiometabolic units are now implemented in different countries to optimize diagnosis and control of metabolic risk factors. We join global campaigns such as Go for Red, World Heart Day, and World Hypertension Day. Medical education, SIAC upcoming next Congress, SIAC issues Blue Book of Cardiology. SIAC provides inter-American clinics, including one of atherosclerosis. SIAC's website includes summaries and conference guidelines, or the latest studies are summary. And SIAC position, for example, about vaccines. Vaccine, we know the relationship between infection and cardiovascular risk. Third, advocacy, we held the third summit in Mexico, and 21 institutions were represented at the summit. And for SIAC, the networking and collaborative work is fundamental. Thank you.
There's a lot there to unpack, but I do want to highlight a few things that you said, which is the first is that inflammation is dynamic. It's variable, it's changing, and you highlighted a couple of things. One is race and ethnicity and the role of inflammation. We know it can vary by race and ethnicity. We also know that women can have different kind of trajectories of inflammation compared to men, and menopause is a huge inflection point in a woman's life that can change her inflammatory milieu and change her risk for cardiovascular disease, and something we have not yet quite understood. So I think education and advocacy are so important to try to really implement change. So to that end, Dr. Banerjee, I want to ask you, in terms of education and advocacy being sort of where we need to end up, how do we start at the bedside, really using health systems, which is your expertise, large data sets, to try to start to screen populations so that we're not just, oh, Dr. Chandrasekhar remembered to ask about inflammation, or Dr. Kohli remembered that they had a plaque rupture, but we're actually using the electronic medical records and the data sets that we have to try to systematically identify inflammation.
Thank you. Thank you, Payal. I want to just go to one point my colleague said about vaccines. That illustrates how we have, in the medical fraternity, been in our specialized silos. And you can't talk about inflammation without talking about infections. And actually, there's a top-level evidence-based recommendation for flu vaccination in both primary prevention and secondary prevention of myocardial infarction, but still most cardiologists don't know that and follow that through. That's seen as something for public health people, something for primary care.
Well, you mentioned also dementia, so there's new data on the shingles vaccine and reducing risk of dementia as well.
And we see from, so that's supported by trials, but there's observational data from various countries suggesting that COVID vaccination and probably respiratory syncytial virus vaccination and probably pneumococcal vaccination have an effect. So as the World Heart Federation, taking a global view, the data supports, if you're taking a lifetime risk approach, get vaccinated. That'll do something for your inflammation risk over your lifetime before we get to all the more sophisticated therapies that we're developing in high-income settings and for research.
I like to say that getting a vaccine is like a deposit in your immune system savings bank. It comes back to you with interest all through your life. You keep making more deposits, they add up.
Yeah. So, like we found out across the world during the pandemic, getting vaccinated is important. Avoiding infection is important. So we've known for a long time that people who have hospitalized infection, particularly pneumococcal infection, they have a risk acutely, but also over the next 5 years of an increased cardiovascular risk. So I think there's something there that we can act on globally to kind of join those communities together. We think of cardiology in a specialty or a subspecialty way. You know, that the data suggests that we should try not only to improve our drugs for primary and secondary prevention, but also look sideways and improving our vaccination rates.
Did you want to comment on the large data sets?
Yeah, sure, thank you. I think that as Dr. Chandra said, in terms of risk factors, we need the whole prevention spectrum. So, and you also said from obesity, hypertension, through to MI and stroke. In higher income settings, we have the opportunity to have comprehensive electronic health records, but even there, we have split it into our kind of primary and secondary care or different hospital systems. So there are things that we wouldn't want in low-income settings where there is also growing electronic health record systems. We wouldn't want to emulate those mistakes. We'd want to make registries and data much more universal than we've managed to do in our high-income settings, so that you can look across diseases, across specialties, and monitor those things. So I'd still say globally that the best buy probably in terms of this topic of inflammation is probably vaccination.
Dr. Rivero, I use ChatGPT almost every single day. It helps me make decisions, it helps me know what I should do, and I do it not just personally, but as a physician. Sometimes it helps you also. There are many medical AIs out there that are being developed, so I want you to put on your AI hat and tell us a little bit about, is this pie in the sky in terms of AI helping us find inflammation in our patients, or is this something we're actually closer to than we think?
Yeah, I think that AI is here to change the way we behave, we find knowledge, and we now even helping us to answer messages, emails. So it's something that it's amazing. About AI in health, we have a lot of new developments. They are promising. We expect that we will practice medicine in a different way using AI tools. But we still are discovering models and try to validate them, and most importantly, try to validate them in a prospective way, in a way that we can see how this information is acquired by patients and doctors and can change the way people act. For inflammation, we have mostly two approaches. One is trying to use AI to on imaging. So, as Dr. Chandra said so brilliantly, there are a lot of information in CT angiograms behind the lesion itself. So this fat attenuation index is a marker of perivascular inflammation. And as shown also in his slides, there is a study from the group of Oxford published in Lancet last year that used the FAI, the Fat Inflammation Index, and an AI model for risk factors that showed that we could find those patients with higher risk of coronary events. And this is probably the best evidence we have now for using AI, although it's an AI that uses an imaging data along with clinical factors. So it's not completely like deep learning, something that it has different steps. But it's a proof of concept that it's possible to find risk prospectively finds those who evolved with heart events in terms of cardiovascular disease. We have another approach. We do not have such sophisticated methods for in our center. We have been working with ECGs. So we have a large data set of ECGs acquired from primary healthcare centers, and we established a cohort of 1 million persons with repeated ECGs and with known outcomes. And in this data set, one of our main activities was trying to find the age, the estimated age by DCG, using only DCG signal. So it's a deep learning approach that you train the machine to find the age of the patient. The machine is very accurate on this, but there is an error. So if the estimated ECG age is more than 8 years than the chronological age, so more than the mean error, you are in a situation that the risk factors were more common, and the risk of death and cardiovascular events, myocardial infarction, stroke, atrial fibrillation, and heart failure are much higher. And this has been proved by our group, but also from the Mayo Clinic and other groups. And we now know that this can be a very useful marker of risk that is at least as good as the clinical risk scores. What is very, very interesting regarding inflammation, because inflammation is a main feature of aging. So there is this concept of inflammaging. Yes, when you get older, you get more inflammation. And what ECG age is picking is mostly related with inflammation. So there is a direct relation in the ELSI study. It's a cohort study that we have in Brazil. Those with DCG age gap of 8 or more years, they have much higher levels of inflammatory markers. And this could be also, so that we can get from a simple exam, you can probably find the inflammation, and this could be a very important aspect of this biological aging that we are finding using AI. So there are a tool here that we can use, but it's still to be developed and validated prospectively.
I mean, it's so fascinating, AI, because there's two types of AI, right? One that looks at the present and tells you whether or not somebody's vascular age is older than their ECG age or what have you. And then one that looks in the future, predictive AI models that tell you what's going to happen. So, you know, for me, I'd like to just wrap up the session. I'm going to give the panelists just about 30 seconds because we're over time to make a comment. But I think the biggest challenge in inflammation moving forward is assessing inflammation, not just systemic, as Dr. Chandrasekhar said, but vascular inflammation, and assessing when it's bad and when it's out of proportion, and what we need to do about it, and really implementing those strategies on a more population level so it's not guesswork in the office of a patient sitting in front of you with 7 comorbidities, whether it's the comorbidities or the inflammation that's causing the problem. So my wish for inflammation, and I'm going to ask each of you to make a wish. If you had a genie in a bottle, what would you wish for the future of inflammation in cardiovascular medicine? My wish is that we have either a biomarker or imaging or AI or some large health system problem or a combination of all of those that helps me as a clinician know when I should think about targeting inflammation in my patient to reduce cardiovascular risk. So we're going to go down the line here, Dr. Chandra. What is your wish from your genie in a bottle? What challenges do you see?
Yeah, a low cost, very accurate biomarker for inflammation.
That's awesome. I love it.
Avoid infection, get vaccinated.
Including the MMR in the US, right?
I would go to the basics. Treat high blood pressure, diabetes, obesity, healthy food, physical activity. Physical activity probably is the best vaccination against inflammation.
Can we reverse our aging too? That would be nice.
Yeah, I think so.
Control risk factor and education of the community.
Education is power.
I think I agree with you. I think we need to get to a point where inflammation is included as our assessment of the patient's risk. And I think we're very close. You know, we have the new risk prevention model being integrated into guidelines now. It's going to be published soon. Once we get to that level, that the assessment of inflammation is important in determining the patient's risk, we can begin to take the next step. What do we do about that? So I'm with you on this and want to congratulate you on organizing an excellent symposium.
Thank you, and what a whirlwind. Do we have time for a quick comment from the audience, or?
Mafusha House, Sarasota, Florida. This area which you have interested for the last 20 years, as a matter of fact, cardio-obesity is associated with inflammation, and we have already presented data on that. Not only that, we said the title was Decade of Cardio-Obesity is associated with increased cardiovascular structure and functional abnormality. CRB and BNP is part of the test, which in all cardiac patients, which we screened 3,000 of them. You know that, Dr. Cohn, have put this, the test at your university, and you do that. And we think inflammation precedes the calcium score. The case you presented, exactly, we had that data, we followed up when they're in the 50s or 60s, inflammation, increased CRB, BNB, structure functional changes. Later on, the older people, and the higher the cardio-obesity, the higher the CRB, and the higher the cardiovascular structure change. So no question, cardio-obesity and maybe the real one to look before calcium score. Calcium score is the end stage. Inflammation is the primary.
Thank you so much. I hope this session has left you uplifted, thinking about how to modulate your own inflammation and that of your patients. It's been a scientific whirlwind. I've certainly learned a lot about inflammation. Dr. Smith, quick comment?
One final thought idea. What do you do when you have evolving evidence, it's on social media and so forth, and you don't have guidelines, enough evidence to do a guideline? What generally happens is you write a consensus statement. And this might be an opportunity. It's happened in the past for ACC, AHA, ESC, WHF to come together with some sort of consensus statement on the evolving data associated with inflammation and cardiovascular risk. That would stimulate discussion and bring together more than just a group of opinions flaring up on media.
I think that's critical to changing behavior, because that's our playbook as clinicians. Guidelines and consensus statements are what we sort of guide our care on, so I think that's a fabulous suggestion. So with that, I want to thank our panel and thank the audience for their participation as well. Appreciate you so much.